Thank you very much, Dr. Amanullah, for the elaborative welcome note and precisely summarizing the whole program. Now, I request Dr. Shoaib Luqman, who joined us from Bahawalpur, and he is the budding neurologist, very active neurologist. He has experience in movement disorder, and I request him to start his talk and share his screen so that we will start our first talk of this session. Dr. Shoaib Luqman, Assistant Professor of Neurology, Qaid-e-Azam Medical College and Victoria Hospital, Bahawalpur.
Thank you, Dr. Abdul Malik. I hope you can hear me well. आवाज
जी जी
सही आ रही है सर?
जी जी बिल्कुल आ रही है.
Thank you, Dr. Abdul Malik Saab. It's a pleasure and an honor to be invited to be a part of this excellent CMA activity, and hope we have a fruitful day of learning ahead. And thank you, Dr. Amanullah, for the elaborative introduction. So my job is to talk about the difficulties in diagnosis of Parkinson's disease. As Amanullah Saab and Sir introduced me, I am working as an assistant professor of neurology at Qaid-e-Azam Medical College, Bahawalpur. Well, to talk about the diagnosis of Parkinson's disease, most of the time we think it's pretty straightforward, isn't it? Whenever a patient comes to us with classical signs of tremor, bradykinesia, postural instability, and rigidity, we always have an easy time diagnosing a patient with Parkinson's disease. Most of the time, it is so that the diagnosis is easy. The diagnosis can be made with a reasonable degree of confidence. But with all neurodegenerative disorders, especially Parkinson's disease, we must keep in mind that these symptoms and signs develop slowly over a period of time. All these disorders are insidious disorders and they take a bit of time in developing. So we must keep in mind that whenever we are seeing patients early on in the disease, there is a possibility that we can miss the diagnosis. And this is true and has been proven in many studies. In a 2016 systematic review and meta-analysis published in Neurology, it was found that the diagnostic accuracy of clinical diagnosis of Parkinson's disease was about 80% as compared to neuropathological studies, which is considered as the gold standard in the diagnosis of Parkinson's disease. So we still miss about 20% of the patients with Parkinson's disease, which is quite a large proportion of the patients that come to us with Parkinson's disease. If the patients consulted a non-expert or a primary care physician, the percentage was about 73.8%, whereas for experts, us neurologists, and especially movement disorder specialists, the correct diagnostic accuracy at initial assessment was about 79.6%, and this increased after follow-up to about 83.4%. 83.9%. So that means we were still missing 16% of the patients with diagnosis of Parkinson's disease, and that needs to be addressed. And this is my job today, to make sure that we don't miss that 16% as well. As I earlier mentioned, Parkinson's disease is a slowly progressive insidious onset disease. So there is a diagnostic latency involved in the diagnosis of Parkinson's disease, and different studies showed different diagnostic latencies from the onset of motor symptoms to about to diagnosis, and this ranges from about 11 to 15 months. And this diagnostic latency is greater in men than in women. Probably so, for the fact that men always are a bit reluctant to consult about many different medical problems that might be saving and they have an inhibition going to the doctor with their problems. So the longest delay was for patients with presenting with gait disturbances or global bradykinesia. If a patient comes to us with tremor that is clearly evident or rigidity that can be clearly demonstrated, the diagnosis becomes easy. But for the patients coming to us with predominantly limb gait disturbances or uh, bradykinesia, this diagnosis can often be missed. So we always should be on the lookout for to be patients presenting with gait disturbances or bradykinesia. And if the dominant side was involved, it resulted in a shorter diagnostic latency, whereas if the non-dominant side was involved, it resulted in a greater diagnostic latency. And no, large proportion of non-motor symptoms at onset resulted in a longer diagnostic latency. So if we talk about the commonest disorders that are misdiagnosed as PD, the most common is essential tremor. The differentiation between an essential tremor and a Parkinsonian tremor can often confuse many experts, neurologists, and movement disorder specialists as well. And we always should be on the lookout to differentiate between these two very different diseases and with very different outcomes. The other common disorders that can be missed are drug-induced Parkinson's disease, Parkinsonism, dementia with Lewy bodies, dystonic tremor, vascular Parkinsonism, Parkinson plus syndromes, orthostatic tremor, physiological tremor, focal dystonias, and Alzheimer's disease. Alzheimer's disease can also present with Parkinsonism, and we always should be careful in making a diagnosis of Parkinson's in patient presenting with memory and cognitive impairment. So what are the aids in early and prompt diagnosis? Parkinson's is a clinical diagnosis, and till now, we don't have many ancillary tests or diagnostic studies to prove the diagnosis of Parkinson's disease, and the diagnosis remains mostly clinical. So, though there are certain things that can help us in identifying the early diagnosis of Parkinson's disease, and remember, earlier the diagnosis, the prompt is the treatment and the better is the outcome. So there is a specific Parkinson's prodrome in which I'll be discussing in a short time, and we must always be ready to identify that Parkinson's prodrome and its importance in development of motor Parkinson's disease. The, we should have a core knowledge of differential diagnosis of different cardinal features. We should always be on the lookout for non-motor symptoms, autonomic abnormalities, and behavioral and cognitive symptoms. And we should be able to identify the red flags, which I will discuss shortly, that can point towards a potential alternate pathology. So what is the Parkinson's prodrome? Different neuropathological studies have proven that Parkinson's neurodegeneration in Parkinson's disease begins decades before the appearance of motor symptoms. What is prodromal PD? It is a clinical syndrome that does not fulfill the diagnostic criteria of PD, but exhibits signs and symptoms indicating higher than average risk of developing motor symptoms of PD in future. We must always keep in mind that most prodromal features are non-motor, but they do impact quality of life. Now I'll be talking about some common prodromal features. The most commonly that we miss is hyposmia or sense of smell disturbances. It is disturbed in about 90% of patients with motor Parkinson's disease uh, at the time of diagnosis, and often we miss testing it and we miss identifying it. So we should always test the sense of smell in a patient presenting to us with motor disturbances and see if he has any abnormalities in the sense of smell. Constipation is another very important prodromal features. It sometimes appears 20 years before the onset of motor Parkinson's disease, And studies have proven that individuals with less than one bowel movement per day are 3 times more likely to develop Parkinson's disease than those with greater than one bowel movement per day. One prodromal feature that comes relatively late in the onset of motor Parkinson's disease is mood disturbances. Most of the patients, when they are diagnosed with motor Parkinson's disease, they do have some anxiety and depression, which becomes evident usually about 1 to 2 years before the diagnosis of motor Parkinson's disease. The most thoroughly studied and the most proven prodromal feature with Parkinson's disease is REM, sleep behavior disorder, and it has the highest risk of phenoconvergence to motor PD. 50 to 70% of polysomnographic confirmed REM BD patients will develop a synucleinopathy that includes Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy within 5 to 10 years, with PD being the most common. And often with hyposmia and other prodromal features, the patients themselves may not be aware of their abnormality, and a collaborative history from the caregiver and their partner, spouse, etc., is very necessary to confirm the diagnosis of prodromal PD symptoms. So if we talk about the cardinal features of Parkinson's disease, bradykinesia, rigidity, tremor, and postural instability, there are some clues, certain clues that can help us in identifying these cardinal features at an early disease. If we talk about bradykinesia, this is a required feature in both UK Brain Bank and MDS criteria, and it is present in 80% of patients at disease onset. It is usually checked by performing different tasks such as finger tapping, hand opening and closing, supination, pronation, toe tapping, and foot stomping. Uh, the problem with us, especially working in busy clinical environments such as Pakistan, is we don't have much time to spend with each of the patient. So often in our hurry, we miss these things. Whereas the studies suggest and the data suggests that each of these movements and each of these maneuvers should be tested for about at least 10 seconds in each limb. And it should be always kept in mind that the onset is always unilateral and it always remains asymmetric. The movements initially may be normal, but they progressively become smaller and often pause with repetition. There are other features such as micrographia, writing abnormalities. Patients often consult the doctors as a presenting feature with micrographia. They have the inability performing activities of daily living, such as difficulty buttoning their shirts. Often they have hypophonia and hypomimia, the flat face of Parkinson's disease. You must be wondering why I have added so many pictures of चौधरी शुजात हुसैन. एक तो बात यह है कि अब्दुल मालिक साहब की मौजूदगी में सियासत का जिक्र ना आए तो ज़रा फीकी सी महफिल रह जाती है, और दूसरी चीज़ ये है कि चौधरी शुजात हुसैन is probably the most identifiable Parkinson's disease patient in our country right now. So I hope you can make this smiling person with a broad smile in between Chaudhry Nisar Ali Khan and Ghulam Haider sometimes in early 19s and 90s, and many of you may not be able to recognize, but this is what Chaudhry Shujat Hussain was before the onset of Parkinson's disease. And this collage that I have made is specially made for you to identify how the hypomimia or the flat faces of Parkinson's disease affects the face of a person. This probably is at the start of his disease. As the disease progressed, you can see that his face became expressionless, flat, and right now he is at this stage. So you can all see that the anterocolus that usually develops with Parkinson's disease is there, the flat face is there. Another very important thing is blink rate. Blink rate can give you clue about the Parkinson's disease and bradykinesia at an early stage. The normal blink rate in an individual is about 24 per minute, and it is decreased to about 10 to 12 in Parkinson's disease. It is decreased even lower in Parkinson's plus syndromes such as progressive supranuclear palsy. But we must always look at the face of the patient and see if his expressions are normal, his blink rate is normal, his overall whole of the expression is normal. Now, if we talk about the other cardinal feature, that is rigidity, it is defined as velocity independent passive resistance to movements. The typically rigidity that we see in Parkinson's disease is cogwheeling with a ratchet-like quality. Cogwheeling where अगर आप लोगों ने कभी टांगे पे सफर किया हो और उसके अंदर आप सफर करें और उसके अंदर जो एक उसका व्हील था, क्योंकि वो लकड़ी के बने होते थे और उनके ऊपर वो एक कॉन्स्टेंटली आपको एक मूवमेंट के अंदर एक वाइब्रेशन सी फील हो रही थी। जैसे ही आप पार्किंसंस के पेशेंट को भी चेक करेंगे, उनके अंदर भी ऐसे ही आपको एक रेंज ऑफ मूवमेंट के अंदर एक वाइब्रेशन फील होगी। ठीक है। The typical cogwheeling is present in about 75 to 90% of patients with PD. But sometimes patients do have lead pipe rigidity as well. So we must keep that in mind. The rigidity causes typical striatal hand that can be seen in advanced Parkinson's disease. Another very important point that we can use to identify Parkinson's disease, especially at an early age of disease, is decreased arm swing. Whenever you ask the patient to walk, uh, always look out for the arm swing. Is it comparable and equal in both arms? As the Parkinson's is always an asymmetric disorder, it starts from one side and remains dominant on one side. Usually the arm swing is reduced on the side that is involved. So if you observe unreduced arm swing in a patient suspected of Parkinson's disease, that points towards the diagnosis. The stoop posture is also seen with rigidity. Another very important sign that over the years has been very useful in identifying early rigidity is Kinnear-Wilson maneuver. Kinnear-Wilson was one of the pioneers of Parkinson's disease, and after James Parkinson's, he did a lot of research and writing about Parkinson's disease, and he observed that rigidity can be brought about by having the patient perform repetitive tasks using contralateral limb or mental and arithmetic. You ask the patient to do repetitive tasks such as finger tapping or toe tapping in the contralateral limb that is being tested, and the rigidity becomes evident in the limb that is being tested. So, talking about the tremor, the typical Parkinson's tremor is pill rolling tremor, that is moderate frequency, low to moderate amplitude, resting tremor. It is assessed by asking the patient to sit with his arms and hands supported, sometimes brought on by making them perform a mental task. We must keep in mind that the Parkinson's tremor is a re-emergent. Some of the patients with Parkinson's disease, they have a re-emergent tremor. If we ask them to hold a posture, that tremor can re-emerge or reappear after a short latency. And this latency is again a very important sign that can make you that can help you in differentiation between essential tremor as well as Parkinson's disease, because people with essential tremor have a less latency than Parkinson's tremor. So the Parkinson's tremor appears after an interval of few seconds whenever we ask the patients to hold a posture such as outstretching their hands. Often the patients have an intermittent tremor in early disease, and there is a sense of internal tremulousness in the absence of observable tremor in some patients. And it always becomes obvious as the disease progresses. The frequency is usually between 3 to 7 hertz, but mostly between 4 to 5 hertz, and it is a presenting symptom in about 70 to 80%, and it is present in about 80 to 100% of the patients during the course of their disease. It can involve legs, lips, jaws, and tongue as well, but rarely head and voice. Uh, the isolated head tremor or isolated titubations are rarely a sign of Parkinson's disease. Most of the time, they are a sign of dystonic tremor, or if sometimes accompanied by other findings, they can be seen in essential tremor, but head tremors or titubations are rarely a sign of Parkinson's disease. As with all tremors, it is exacerbated in anxiety, emotional excitement, and stressful situations. Um, uh, Dr. Nabil will be talking about different autonomic features and non-motor symptoms. So I have excluded them from my study as well as postural instability because Dr. Nabil will be talking about them later. So there are certain red flags in diagnosis of Parkinson's disease that point us towards some alternate pathology. As discussed earlier, Parkinson's is a slowly progressive onsetous disease, and whenever there is a rapid progression within 5 years of diagnosis, we must start thinking about some other diagnosis. If there is a rapid progression to gait impairment requiring regular use of wheelchair within the 5 years of onset, then we can be suspicious of some other diagnosis. If there is early bulbar dysfunction, severe autonomic failure within 5 years, then we should be looking for some alternate diagnosis. And if the patient has recurrent falls within 3 years of onset, that also points towards some alternate diagnosis. And on the other hand, if there is an absence of progression of signs and symptoms over 5 or more years, then probably excluding obviously stability related to treatment, then it is again a sign that this disease is not Parkinson's disease but something else. If there is disproportionate enterocolors or contractures of hands and feet within 10 years, unexplained pyramidal signs, bilateral symmetrical Parkinsonism, that all is also included in red flags in Parkinson's disease. Now, there are some absolute exclusion criteria, which when we see, that means that this is not Parkinson's disease. If there is unequivocal cerebellar abnormalities, or if we have downward vertical supranuclear gaze palsy or selective slowing of downward vertical saccades, obviously these 2 points towards Parkinson's plus syndromes. Uh, uh, the diagnosis of probable behavioral variant frontotemporal dementia or primary progressive aphasia within the first 5 years, that is again an absolute exclusion criteria for Parkinson's disease. If the features remain restricted to lower limbs for the more than 3 years, then this is also excluded from Parkinson's disease. Again, drug-induced Parkinson's. If there is clearly cortical signs, cortical sensory loss, clear limb ideomotor apraxia, or progressive aphasia, then this is again excluded from the diagnosis of Parkinson's disease. Although functional imaging is not normally done in patients of Parkinson's disease, but if the patient has a normal functional imaging, and then this is also excluded from the diagnosis of Parkinson's disease. The conventional, if we look at the ancillary testing that we can use to help identify the diagnosis of Parkinson's disease, the conventional MRI is usually not very helpful in diagnosing Parkinson's disease, but it can be used to identify or to rule out other causes of Parkinsonism. Some advanced MRI techniques such as MR volumetry, MRS, magnetization, transfer imaging, diffusion weighted imaging, diffusion tensor imaging, high resolution imaging with 3 or 7 Tesla machines are all being studied, but they are not part of the routine workup right now. DAT scans can be useful in differentiating patients of Parkinson's disease and differentiating them from essential tremor or other disorders, but the DAT scan is still limited, that it can not differentiate between Parkinson's disease and other nigrostriatal degenerative syndromes such as MSA, PSP, or CBD. So again, its clinical efficacy is limited, and studies have shown that DET scan sensitivity and specificity remains equal to a precise clinical examination. So again, the clinical examination remains the best tool for the diagnosis of Parkinson's disease. The PET scans have a greater efficacy than DAT scans, but they are again not very widely used. And last, different biomarkers are being developed, such as CSF and blood alpha-synuclein species, lysosomal enzymes, markers of amyloid and tau pathology, and neurofilament light chains. They are slowly becoming available. They are becoming a part of the testing profile in larger centers, but they are not used clinically in usual settings, especially in Pakistan. So thank you.